A very happy National Doctors Day to all of you.
Thank you so much.
Very good evening and welcome to one and all. I am Momita from Clanet, the designated station assistant for a seamless experience. And Clanet is India's most trusted and widely used digital platform with multiple engaging services exclusively for doctors. Planet is very proud to be a digital partner for this event organized by Indian Academy of Pediatrics, Gujarat. And the topic of today's session is case discussion on GBS. So let's begin today's session, for which I would like to invite Dr. Neha Patel ma'am to take over. Over to you, ma'am. Please proceed.
Yeah, thank you so much. Uh, I thank Clarinet for providing this platform for the PG teaching, and I welcome all to e-Gurukul Pathshala PG Clinic, which is a very favorite program for in all the PGs. Today we have a case discussion on the nervous system, and for this case discussion, we have presenter Dr. Sayan Kumar Das, who is a second year resident from GMERS Medical College, Gandhinagar. And I also welcome his mentor, Dr. Nisha Prajapati. She is Associate Professor in the Department of Pediatrics at GMERS Medical College, Gandhinagar. For this, we have two renowned experts. And for this, I welcome Professor Dr. S. Manjir Ali, sir. Uh, sir, sir has done his so many degrees like MD, DCH, DMB, DCH from the Glasgow, and he is fellow in the HIV medicine, FIAP, and FNN, a fellow of NNF also. So we are really very much fortunate to have Sir in on our platform. His achievements, awards in papers and chapters in the books are so many. He has guided so many students for the thesis, MD thesis, and the PhD guide also. He has project collaboration with the UNICEF, WHO, USIDs, and MCHI piece. He is reviewer in so many journals like renowned journals like Indian Pediatrics, IJP, and Journal of the Tropical Pediatrics, Pediatric Infectious Disease Respiratory Medicine. He is head of department, deputy director, and director of the medical attendance scheme of AMU, national executive board member of IAP, and president UP chapter. So, welcome, sir. Hello.
Thank you very much, madam. Thank you very much for this one.
Yeah. We have another expert, Dr. Chandana Bhagwat. Madam is a certified developmental assessment scale India basic training, and she is a consultant pediatric neurologist, also working as an assistant professor at MGM Medical College, Navi Mumbai. She has received International Scholarship of American Academy of Neurology for attending the annual meeting of 2022 at Seattle. And she received the first prize in the paper presentation in Association of Child Neurology National Conference. Welcome, madam.
Thank you so much, ma'am. Thank you for the opportunity to be sharing this podium with so many eminent and experienced pediatricians.
Baldev sir doesn't need any introduction, but we are so much glad and actually fortunate to have sir every time in our platform to guide the PGs all over the India. Welcome, sir.
Thank you.
So I hand over the session to sir. Sir, we have many PGs like Chinmay, Aarti, Mayur, and the presenter is Sayan.
Right. Good evening, friends. Welcome to this Saturday PG clinic. I think just for the sake of information, that flow of the discussion will keep in such a way. I think there is some change of voice due to viral infection, but I'm sure that it is audible and you can bear it. I think first the presenter will start the history part. We'll listen to the history. And from the history, whatever the points are there for the discussion, I think first the student should participate. And then we'll go to the expert and then examination. And I think in that way, We'll develop the case and ultimately we'll come to know that what's the condition and how we can manage it. With this remark, I request presenter Dr. Sayan to share his PPT and start the history. Dr. Sayan, please.
Thank you, sir. Good evening, respective faculties and all eminent audience. I'm just sharing my PPTs.
Yes, it's full screen
In
now,
the
Sayan.
beginning,
You can
happy Doctor's Day. Myself, Dr. Sayan Kumar Das, second year Dean Pediatric resident from GBS Medical College, is presenting the case under the mentorship of Dr. Nisha Prajapati ma'am. In our case, informant is mother, Miss XYZ, 3-year-old female child from Sector 22, Gandhinagar, Hindu by religion, non-consequous marriage, has admitted in our hospital on 1st of June with the chief complaint of inability to walk for 2 days. In the history of presenting illness, the patient was asymptomatic 2 days prior. Then she started having inability to walk since afternoon. The inability was sudden in onset, gradually progressive in nature, first affected both the lower limbs, and she was having difficulty in walking initially, but she was able to wear slippers at that moment of time, which gradually progressed and involved upper limbs also. The child was not able to raise hands later on, but able to hold pens. It was also associated with difficulty in breathing. Patient was initially taken to a private hospital before 2 days of admission. Patient was intubated there and kept on 24 hours, and patient was on nasogastric feeding. Then the patient transferred to GBS Medical College, Gandhinagar after 24 hours with bag and tube ventilation. There was no history of visual disturbances, difficulty in closing the eye, or a deviation of angle of mouth. There is no history of blowing, difficulty in blowing or hearing, and bladder and bowel was intact. There is no altered sensorium, headache or vomiting history was there. There was no involuntary movement was present. No history suggestive of any trauma, fall or recent IM injection was there. No history of any throat pain or swelling. No history of intake of any medicine or substance was there. There was no history of drooping of eyelids or increased weakness of the limbs towards the end of the day. In course in our
I
hospital, the
think
patient was
Dr.
kept
San, Dr. San, before you go further, for a while, can you stop sharing? I think you have given the very interesting story of the patient. All of us know that at the end of this management, everybody knows the diagnosis. But when the patient enters your room, I think it's very difficult to answer. And that's the story which we want to discuss, that how we will try to think what should be our thought process and how we will proceed further. And on the contrary, here, the way in which we are listening to him, even the first 2 slides, that there is a fast deterioration of the patient. In that situation, even the clinician has no time. So it's very important that how the clinician is managing. You know, here you don't have the, Dr. San, can you just stop sharing? For a while, till I think we discuss the whatever the information you have provided. And that's very important that, can you just stop sharing, Dr. Sayan?
Sir, your voice was not clear, sir.
Okay, you are not able to manage. I think you know the Z icon is there at the top. where it is written the stop sharing. If you press it, I am sure that it will work.
Hello, sir. Hello.
Hello,
Sir.
are you able to listen? Am I audible? Dr. Sam?
Yes, sir, you are very well audible. I think
Yeah,
there is
yeah,
a
yeah.
problem with Sayan's
Yeah, yeah. Anyway,
internet.
this is
So, Sayan,
also,
are you there?
Yes, sir, ma'am.
yeah,
Now it's
yeah.
clear, sir.
Okay, okay. I understand. And this is also the part of learning for all of us. You know, these type of the obstacles are going to be there, either in the technical management or even the management of the patient. And that everything we'll have to learn that how best we can manage. I think the first question to all other students that you are sitting in your OPD and parents enter your room with the complaints what he said that 3 years female not able to walk since 2 days. Chinmay, what questions you will ask? Just complain, not able to walk since 2 days, for 2 days. What other questions you will ask? What will be your idea? How you will proceed further?
Sir, first, I would like to rule out whether it associated with any infection like
No,
any fever.
Dr. San will be the last
Okay.
person. He'll be the last
Okay,
because
okay.
I'm sure you must be knowing all the details of the case. So we'll
Okay.
come to you at the
Okay.
last. Yeah, later others, and I wish that everybody should discuss, all the students, and keep your video on even, so that at least we can see each other. We feel that yes, we are as if we are talking in the classroom. You know, that feeling is also very important. And the same thing happens in the exams also. So I think that's why this platform is not just for the case discussion. Case is the illustration, just example. From that, all of us want to learn so many things. How to present, how to prepare this presentation, how to speak, how even we gather the information, how we analyze, and even respond to the various questions which comes by the examiners or the experts, right? So, Dr. Chinmay, can you start it? That how will you take this complaint?
Then the parents coming with complaint of weakness, inability to walk. First, the first question which will come to my mind is whether it is a neurological condition or not.
I think what
Mhm.
questions you will ask, what questions you will ask.
Mm.
And that is the thing which I wish to share with all the students. Never make up your mind to reach to the condition. Try to understand what mother says. I will say why neurological. What information you want to decide.
So regarding the presenting complaint of this patient, I would ask how
Okay?
did it start?
Yeah, that's the point. Exactly, Chinmay. What will be your next question? That how the parents noted not able to walk. What the child was doing before that. Was it sudden? Was it gradual? That sometimes the child is having some difficulty in walking and so that remained for a day or two and then now not able to walk, or suddenly the child was supposed sleeping and in the morning found that not able to walk, or even so that type of parents may not be knowing that how to describe it, but I'm sure that that information is very important for the clinician. So I think here, Dr. San, can you say exactly that what was the situation, how the
Sir,
parents noted?
sir, we will ask about the onset, the progression, the
No,
involvement.
San, I think this type of the books discussion should be in our mind. When we
First,
are
sir, I will.
when listen to when we are presenting, it should be like the story, as if we are talking. Of course, these points will be there in your mind, but I will say for undergraduate presentation, it's all right. That you will speak that now origin, duration, progress, now the past history. But I think as a clinician or a postgraduate student, when you are talking, when you are presenting, it should be the very lucid story. Somebody would like to listen to them. And from that, you are deriving so many important information. Should be like that. So taking that perspective with that idea, yes, please again start it. What the child, how the parents noted this inability to walk for 2 days. Dr. Sayan, there is no need to share.
Okay, sir. So the patient first noted the child was apparently all right 2 days back. Then the parents first noted that she was not able to move the limbs, inability to walk.
How?
But that time she
How?
was
How they noted?
means from the sir sitting position, she's not able to uplift and able to walk. But though
Okay.
she was able to wear the slippers, sir, but
Okay.
she was not able to move that thigh muscles, and so for that she was not able to walk. So
Okay.
they think that it might get relieved within few hours or so. But when it get progress, so they become sir worsened. Why it's not been limited, why it's not been improving. After that, sir, what happens? She's not able to lift the arms and all. Means in the
Okay.
upper limbs also.
Okay. I think your story is clear. What is my idea? You know, the way which you describe that initially some weakness was noted. Later on, probably it progressed. And gradually, parents found that now the child is not able to walk. Even with further progression, they noted that even there is some problem with the upper limbs also. So, you know, that gives us the idea that, of course, it is acute onset, it's a progressive, but I would say fairly the progress is there. You know, it is not that the previous moment child is normal and suddenly not able to walk. Suppose if that type of story is there, what does it indicate? Suppose if I say that the child was absolutely all right walking, and even in the evening, child slept, and in the morning, parents suddenly found that now not able to even move the limb at all. Suppose that of the story is there, what does it indicate?
Maybe
Or
sir,
for,
in it
or you know that suppose there is some road accident,
that's
and
what.
previous moment child is normal, next moment not able to move at all. So that of the catastrophe. What various reasons you will think?
Yes,
Yes,
sir.
Dr. Anna, please.
Vascular cause.
Okay, I think this is
Vascular cause.
okay. You know, we want to give the various situations to understand. Ultimately, we'll go to the experts who will explain us the whole story. But the point is that suppose this type of story that may be suddenly some vascular embolism, and then that part of this will be involved, or even trauma.
Trauma, sir.
The trauma will be having the sudden history. So here I think it is not that type of the acute or hyperacute story, but of course acute, and it is the gradually progressive. Then what does it indicate? What does it indicate? What type of the disorder it is? Is it inflammatory? It is traumatic? Is it vascular? Is it some degenerative? Is it some due to the space occupying lesion? What type of the story? What we can consider?
So most likely from this up to this much, we can say only key inflammatory or maybe some degenerative like this
Okay.
only. Traumatic or any vascular events means their progression is
Okay, I
not
think
like this.
fairly good, fairly good. Even you, if you don't consider all other things, you may not be clear at this juncture. But of course, again, degenerative, you know, it takes very long time, even not few days. I think here it's a few hours or few days, and that indicates usually acute onset. And as you said, it is progressive. Now, what is the way of progress? What is the pattern of progress? Chinmay? I think he described that initially some lower limb weakness, then even not able to walk, then even the upper limbs. So what does it indicate? What is the pattern of the progress? Dr. Aarti?
Sir,
Sir,
ascending paralysis.
ascending to
Yeah.
ascending weakness.
So,
Ascending
so,
that.
so try to understand that the disease process is the ascending pattern, right? So acute onset, gradually progressive, ascending pattern, right? So I think, what is my idea? Try to derive these type of meanings from the story. Disease diagnosis may be the anything. We never know the immediately. And if we know, probably it may not require this discussion. But even to reach the very uncommon condition, we should have this type of the thought process. This is just to sensitize the students that how we should go for the thought process. Okay, then what further, Dr. San, you say afterwards is progress, and then what else?
Afterwards, sir, it involves the upper limbs. In the upper limbs,
Yeah, I
child
think you
was
said
initially
some difficulty in respiration. Arti, what does it indicate?
Sir, that shows that respiratory muscles has also been involved. Diaphragm is also
Yeah,
involved. Sir.
that's the point. I will ask the question in some other way. I think Dr. Isha is there. Isha, would you like to answer? Suppose
Yes, sir.
such a patient is hospitalized in the morning with some weakness. Somebody said in your ward, you are on call. I think you understand. How will you watch this patient for respiratory involvement? Because I'm sure that you are alert that yes, it can involve the respiratory muscles and it can cause the respiratory problem. It may require ventilatory support. So such a patient, how clinically you will monitor? Clinical monitoring
Sir,
of
for
such patient.
the sir, test and for that,
Isha, I think there is some problem. There is some problem of Nate. Your voice is breaking. Anyway, I think Mayuri is ready to answer. Yes, Dr. Mayuri, we can take it.
Yes, sir. Sir, in monitoring, sir, the child will have difficulty in swallowing and deglutination, and
Okay.
the respiratory efforts will be very severe.
How will
So, maybe
Dr. Mayuri, your point is valid, but for the respiration, how will you monitor clinically so that you understand that, oh, the problem has started?
pattern of
And
respiration,
pattern
sir.
of respiration, sir.
absolutely. What would be the
Hmm.
pattern of respiration? Very good.
Seesaw type pattern because of diaphragm
I think
paralysis.
that will be quite late, Chinmay. Before that, here we want to monitor as a clinician so that before the patient worsens, before the patient even there is a progressive problem, I should be able to identify and so that I can take the very appropriate steps. For that reason, I'm asking for the clinical monitoring. One is the
Sir,
respiratory distress, yes. For that, how will you monitor? I'm sure you must have heard what is the breath count test. It's very
Yes,
simply
sir.
you can do. What is the test? Anybody knows?
Single breath count.
sir, it's a
Yeah,
single.
yeah, Anna, what is the single breath count?
We have to ask the patient to count in a single breath. If the baby is able to count till 15 in a single breath without breathing, we can say safely the respiratory crisis is not occurred.
I think these are the
If it
questions which the
is less
people
than 15.
okay, these are the questions which people are going to ask, and if something nobody is asking, at least you have to monitor as a clinician. First patient will complain of difficulty in breathing. And then when you are monitoring, even he will find difficulty in speaking, not able to complete the sentence. When you are talking to the patient, even you notice that he is finding difficulty in walking. And once you ask for even this single breath count, you can, somebody ask you in the exam that how will you perform that test? Ask the patient to take the deep breath, deep inspiration, and with single breath loudly he should count. Not just I will say murmuring. He should loudly count. And then you can see up to what he is able to do. Even less than 15, I think it indicates difficulty. Most of the people should be able to do 40 to 50. Right. So I think this is simple test. The difficulty is speaking, not able to complete the sentence. Single breath count is having the problem. Respiratory distress you can see. And I think that's the point even which indicates to the clinician that yes, now there is not only upper limb or lower limbs, but the respiratory muscles are also involved. That's the point that how you can say. Similarly, this patient can have the problem of bulbar involvement. So how will you, Arti, you will try to understand that is there bulbar involvement to this patient or not?
Sir, by asking the child to cough or by gag reflex.
Okay, anything else? Even there may be some complaints.
Easy breathing would be the
Yes.
noisy breathing.
Yeah, rather than noisy breathing, what do you say? There is some difficulty again speech.
Nasal twang and
Yeah,
nasal regurgitation of
one is that nasal regurgitation, nasal twang, right? Dysphonia or difficulty in speaking, that articulate dysphonia, that phonation has affected, difficulty in swallowing, even nasal regurgitation, nasal twang, drooling of saliva. You know, these points will give the idea that, oh, this patient is going for these bulbar issues also. What was my point to sensitize you that once such a patient is hospitalized, I think you should know that it can go for all these problems and complications. And we should be very alert. We should be ready to monitor. And something happens, the next step, what we can take in the management. I think that's the point which you should. I think before now we go further, Dr. Sain, just you have taken very long list of the negative history. Can you give without sharing the, I will say, PPT, can we just take one point one by one? I think it is very important for other students and for us to learn. What is the importance of all these points?
Sir, to rule out.
No, you can take one point.
Okay.
And then what is
Any
the importance?
recent history of trauma?
Okay, I think that already we discussed that it will cause a different story.
Any recent history of any intramuscular injections?
Okay, well, what is the importance?
For ruling out any traumatic transverse myelitis.
With transverse myelitis,
traumatic neuritis, sir.
Okay, but you know, in the past, when we were students, we were asking with some other reference. Or many a time patient will come that the weakness developed following the intramuscular injection or some vaccine was given.
Gluteal region pain.
You know, that is a precipitation of poliomyelitis. I understand this generation will not be able to think, and you are most fortunate, most lucky that you don't know the poliomyelitis at all. That's good. But we have seen plenty of patients. I remember in 83, there were some 18 patients in one emergency day. And out of 18, 11 patients died due to the bulbar poliomyelitis in Civil Hospital Ahmedabad. And these patients were present, and this was a very common story. Following some vaccine, following some intramuscular injection, so many general practitioners were giving the intramuscular injection during those times. Fortunately, now the scenario had changed. So I think that may be the reason. Of course, trauma and other things, what you said is right. Okay, next point.
Any bladder bowel involvement, sir?
Okay, what is the importance, Dr. Arti? Involvement of bladder and bowel involvement is such a case. What is the importance? Why we are asking? Yes, Dr. Anna.
Transverse myelitis.
Okay, you can differentiate some of the conditions presenting like this, that in which conditions this will favor, this will unfavor, right? Dr. Anna, meanwhile, I will say, try to improve your net so that your voice cannot break and you can participate with I will say, without breaking the voice. Okay, Dr. Sain. Dr. Sain, what was the next point?
Sir, any history of any diurnal variation of weakness like we seen in myasthenia gravis and all?
Okay. What next?
Any history of, sir?
But I think for the sake of, if you complete it's all right. But in such a story, do you expect this? What will the common presentation of myasthenia gravis, Dr. Mayur? Do they present in this way, that weakness lower limb than upper limb?
No, sir. Myasthenia gravis never presents with ascending paralysis.
So what are the common presentation? I think suppose some other patient may come to you with this myasthenia, you should be able to identify how they commonly present. What are the complaints? Or what other things you can see? Yes, Dr.
Diurnal variation of weakness. Variation of weakness. Ptosis.
Any other thing? Okay, ptosis. Right.
And improvement with rest.
Okay, please remember, usually without even the manifestation, most common complaint is fatigability. That person is finding that in the morning I'm fine.
Fatigability, exercise intolerance.
As I go for the work, I'm getting fatigue. In the evening, I'm not able to do anything. That fatigability is the main complaint. Of course, with that, as you said, maybe the ptosis, maybe the difficulty in vision, and then maybe even the ophthalmoplegia, right? So I think these will be the problems. Of course, later on respiratory and everything, it possible depends upon its severity. But I think it's a good point. Dr. San, further.
Sir, any history of any altered sensorium, headache, vomiting?
Okay, what was your idea?
Idea to, sir, rule out any IXOL means any space occupying lesion or any means intracranial infection,
Okay,
meningitis.
which meningitis will present with a lower limb weakness than upper limb and progressive, like that meningitis. Which meningitis? Bacterial meningitis, tuberculous meningitis. Which meningitis will present in this way?
Encephalitis can present with this
Encephalitic, sir,
presentation.
mostly.
Okay, what is my idea? That negative point should be taken concern to your case. Standard textbook has given the standard keeping in mind all conditions. But I think you should select according to, I would say, as you know, we should have the improved vision. That, for me, this my case probably may not be relevant. Somebody is asking, okay, but I think you may not mention in your story. Okay, no problem. Further?
Further to, sir, any history of any involuntary movements? Up to this much of history, sir, involuntary movements and all not that much relevant.
Yeah, so I think don't go, right? But I think what is another point, which important points on the contrary you have missed, which you should ask in the history. Any other student?
Toxin.
Others can ask.
Toxin, bites.
Toxic medicines that I mentioned. Any
Medicines,
toxins,
I think he had mentioned.
anyways,
Toxin.
anti-neoplastic
Bites.
medicine, vincristine, vinblastine, like this,
Okay,
or any
okay,
substance like
that's
lead
good.
poisoning and all, lead and all.
Okay, I understand that you have read a lot.
Acid.
That's good. But you know, then we'll have to apply that which comes to there. What is the common story in such patients? Any, I would say, some illness before 2 weeks, before 2 weeks, 10 days, 2 weeks.
Preceding illness, GI issue.
Yeah. So any upper respiratory viral infection, GI infections, because they are known. History of any specific vaccination. Right. I think that you should mention.
But
Which
that was
vaccine?
there in our case, sir.
It's a different, we don't know, I don't know the case, but you know, that's why I'm telling you, if you are knowing, you will ask your. Sometimes parents may not even complain, but then they will say, yes, sir, vaccine is given or some medicine is given, because they don't know that what is the correlation. So as a clinician, I think we'll have to, I think there may be the several points. My point was, in the negative history, what should be included? Whatever, I will say, thought process, whatever you are considering, and which helps you some other points to strengthen your possibility. Or probably some negative absent, it excludes the nearby differentials so that your thought process becomes clear. And third, some known complications of the condition so that you come to know whether the patient is present with a complication or without complication. So I think that should be thought process. I think before we go further, we will take the help of experts. Dr. Manjir sir, please. You can add so many things. I understand. We are here there to learn from you. Please.
Thank you, sir. Nishan, you have presented nicely the cases.
Thank
but
you.
As the Prajapati sir has told about that you should go in a stepwise manner. And it's not like an MBBS that we are going to be there. Of course, this child was presented with a sudden onset, right? Which was important. And this sudden onset must be probably either it may be happening to be vascular in origin, is to be kept in mind. And apart from that, there are any other things to be there on the bed, trauma and all we have taken.
Yes.
You should be very especially taken. You have told the injection giving rise to. So sciatica injection is, you might be thinking, but actually it was earlier, it was the polio which may be presented as the, we have told about that, right? Apart from that, some foods intake is also, is there some food is cane food or some food can give rise to this?
Botulinus.
What should always be kept in mind that this happened to me. In some time of our India and other places, we can get some infestations. And which is that infestation? Ticks. Or this can be.
Paralysis.
So we should always kept in mind.
Yes,
Not
sir.
like that is heading on the way, and we should see this. Apart from that, you have taken the myasthenia. Myasthenia was, of course, as I told about that, is not be giving rise to this. Mainly, it presents the ocular, and here this child developed a usually having a proximal muscle weakness. Initially started, sudden in onset happened to be there, progressive in such a way that they went into the ventilator. So you can imagine if you don't monitor that. When you are looking after them, the clinically as the breath count is a very, very important that has been told. Apart from that, we have to be a vital capacity. We can take them on the way that how can we heal. So we can do clinically and the gadgets. So clinically is a very important that you can do that. And in clinically, you wanted to know that what type of pattern of respiration, whether it's a paradoxical respiration or there or not. That will give a very clue idea on that. Whether this respiration, usually this type of the patient, they don't have a tachypnea and all. They are usually presented with a difficulty. So we have to be. Apart from that, you look into the patient that is there the child is having a progress has been reduced or it is still going to on. And if it is going to be there, it should be kept in mind that this should be a disaster for that. For gadgetry, we are getting to be a oxygenations, of course, because that will be play important role. Here, this important is the diaphragmatic, if there is a diaphragm is involved or intercostal muscles involved, that is also given a clue whether this will be a what type of muscles are being there. When we are taking a negative history, basically when we take the history, our basic aim is we give the poly hypothesis, multiple hypotheses, only on the basis of chief complaint. And then we take the history and we like to narrow down that to give a mono hypothesis that probably this system is going to be there. Suppose I give you an example, a child comes with you with a headache and vomiting, right? Headache and vomiting and the weakness will be paralysis or not. It may be a CNS in origin. It may be a secondary cause of the other reasons. Maybe a renal in origin because might be hypertension and giving rise to the problem. So we should always give rise to a try to rule out the history when you are taking history to narrow down the history on that. But that will play a very important role. And when you are narrow down the history, then you look into the then this what in because investigations are not going to help us. Here examination play a very, very important role. And the exam when you are examining the patient on the way, that will be going to be give the outcome of the patient. Because this patient was advancing very soon. Morning they happen, and in the evening they went into the ventilator. So this is you can imagine very catastrophic. So it's important to look into that. And Prajapati,
Yes, sir. Thank you. Sir. Thank you, sir. Thank you. I think not many points you added. I think before we go further, wait, madam, would you like to add something, Dr. Chandana? Am I right to pronounce Dr. Chandana?
Chandana.
Yeah, Chandana. Okay. Thank you, madam. Please.
Yeah, so you have presented a very nice history, but I'd like to go back to your history of presenting illness slide. Can you show that slide to me?
Yes, ma'am.
Yeah. So when you give a chief complaint of difficulty in walking or inability to walk for 2 days. So if we talk neurologically, causes of inability to walk. So as already discussed, one is weakness, which can be an upper motor neuron type of weakness or a lower motor neuron type of weakness, and other things which we have already discussed as to stroke. Any other neurological involvement you can think of that that can give rise to inability to walk apart from stroke and a lower motor neuron type of weakness, such as an acquired neuropathy, GBS? Anything else you can think of? What if I tell you that the patient had acute cerebralitis, that is why he was unable to balance and that is why he was unable to walk for 2 days? So you have to be very clear in your history as to why he was unable to walk. Okay, so how you should present it, it should be, sir, as sir has already told you, that the whole story should be very clear. So how it should be presented is, she was relatively asymptomatic. In the morning, she was in her usual state of health. She was able to walk to the washroom, she was able to take bath, and whatever her routine daily activities she was able to do. That establishes that at that time she did not have any symptom. After that, this inability to walk. So how did this inability to walk present? Did it present in the form of frequent falls, or did it present suddenly that she was unable to bear weight or walk? Or did it present like she was unable to walk in the form that she was having a wide based gait and she would in between go imbalance and would fall down, and then subsequently she was unable to walk? So that should be written here. So maybe she had initially for some few hours or for few minutes she was having frequent followed by that she was unable to bear weight and she was unable to stand on her limbs. Subsequently but she was able to wear slippers at that time. This gradually progressed and involved upper limb, but you did not tell us whether she was able to stand or not, whether when she was in supine position was she able to sit. So truncal weakness also did not come in your points. And then you went on to involve the upper limb. So you have told that she was not able to raise hands. So this is all these things should also be there. So this establishes that the weakness started from the lower limbs, and this was a weakness which led to inability to walk rather than a cerebellar etiology also. And this was a weakness which was gradually ascending and progressive rather than a stroke in which we think that this is a sudden or a hyperacute onset. So this is how that story should be there. And then you should tell that by evening she was able to chew food, she was able to take milk, or whether she was not able to take milk or whatever, and how her voice was there. Did she have any change in voice, any low volume of voice, or any change in the character or nasal twang of the voice? And then whether that was there or not, and then whether it was associated with any difficulty in breathing and all those things. So this is how a story should be developed, so that we know that okay, what we are dealing with is a symmetric ascending weakness. Okay. And also in your negative history, so you have taken majority of the negative history points that should be taken in this case. But when we are talking of a weakness, then you should tell me that whether that weakness is leading to an increased hypertone, increased tone, or a decreased tone. So how did the mother find that her child's limb were they floppy, were they loose, or did she feel that they were stiff? Many times their tone changes are difficult to ascertain, but one must ask whether they can be whether she has noted them or not. And when there is a weakness, when you are ascertaining that this is a when you are giving me hints that this is a GBS or an acquired neuropathy, then you should comment on the sensory features also. We all know that GBS has paresthesias and sensory paresthesias, etc. also. So that also you should tell whether the child complained of any sensory changes, whether she complained of any limb changes or anything. And also a recent history of infections of an upper respiratory tract and a lower GI tract infection is also important. It is important for GBS also. It is important if we are thinking about a possibility of transverse myelitis also, because all these processes are para-infectious processes. So any recent infection, etc. should come here. So these are my inputs.
Okay. Dr. San, can you go further for your history part?
Okay, sir. Course in our hospital, sir. The patient was kept on ventilator for 8 days since admission at PICU of GMS Medical College, Gandhinagar. Then she gradually went off to a non-invasive oxygen supply for 2 days. After that, the patient was on room air. Patient received 2 doses of IVIG injection and gradually improved till the date of examination, which was 12th day of admission. As the child improved further, patient was shifted to ward. In the recent past history, sir, she had history of loose motion 2 weeks back.
I think just for a minute, it's to all the students. You know, when this type of presentation is there, always keep this course in the hospital at the end, because this you must have diagnosed and managed, and even what in one slide he has described the whole story of the patient may not be that easy. So I think course in the hospital, you may keep at the end whenever you go for this type of presentation. Okay, no problem. You can go further.
Okay, sir. In the recent past history, she had history of loose motion 2 weeks back, 2-3 episodes per day, semi-solid inconsistency, lasted for 2 days. No medication was received that time and subsided by own. She had a history of similar episode 1 year back and was admitted to a private hospital for the same, and she required 62 days of hospitalization for the same, which includes 7 days of ventilatory care. At that time she has been diagnosed a case of GBS and had received 1 IVIG dose. and followed by regular physiotherapy, from which she recovered completely, gradually after within a span of 3 to 4 months.
Okay,
In
go
the
ahead.
birth history,
Yes, Dr. San, go ahead, please.
in the birth history, it's a full-term delivery, cesarean section, cry immediately after birth. Birth weight was 2.8 kgs, no NICU admission history, and breast milk was given within few hours of life. Antenatal history, primary mother registered, no significant history in first, second, or third trimester.
Okay.
Immunizations or vaccination up to age in government hospital, according to NIS, no special vaccine received. Last vaccine 1.5 years back. OPV, all doses taken. BCG scar was present. Family history, non-consanguineous marriage, no similar complaint present in the family, no history of any seizure disorder, any other significant systemic disease or TB contact was there. Socioeconomic belongs to upper middle class according to modified Kupuswami's classification. Development history, normal as per age. In the dietary history, in last 24 hours equal method, prior to that admission, the child was on mixed diet, on non-vegetarian, and no gross protein or calorie deficit was found.
Okay. Can you just stop sharing for a while, because your history part is over. So first, students, any question, query for Dr. San from your side? Wanted to know something, or some clarity is not there, or something is missed? I think all other students should come with the preparations. Active participation is very important for learning. And all other students, I request them that keep your video on. Even not necessarily that you may speak, but at least keep the video on. And San should find the difficulty from your side. Always go for the competition. The next time, then the San will come with the preparations for you. Yes, Dr. Anna, you have any query for your friend?
Sir, should we mention the diagnosis? Should we mention the diagnosis in the past history? Like he mentioned that there was history of GBS. She was diagnosed. So are we allowed to say that in a case?
Absolutely. I think a very good point. Exam point of view.
Sir, in our case, the relatives, the informant mother was learned enough, and she was clearly speaking to the patient, since it's a major event and they have already been counseled from the private hospital about the progress, about the disease, about the outcome. So they know everything. Even the IVIG dose, that was also been explained, and they know the cost, they know the price, everything, sir.
Okay, I think in this type of situation, suppose if you mention, it may not create the problem. But because in the MD examination or DNB, what happens is most of the times you know the case and you mention this everything, even the CT report, MRI report, it invites a trouble. So don't do like that. I think here also, I'm going to do it, but later on. But Dr. Anna has raised a very good question. Okay, anything else? Any other point?
The thing, one more doubt I had was whether to mention the history of loose stool in past history or in history of present illness. Like it is relevant to the present illness, so should we mention it earlier?
I think that it is it in the continuation with this illness, or how the parents even complain. I'm sure that the parent, and that's why what always we say, what was the chief complaint? For what the child was brought to you? Child was brought for the inability to walk. Probably I'm sure that my parents might have not mentioned at all this problem of diarrhea. But with something in your mind, if you ask them, they will mention, yes, it was that 2 weeks back or 10 days back or something like that. So I think it is right place. Right. Better to, because that always, What was the chief complaint? For what the child was brought to you? I think in any case, as a clinician, that should be the point. And I think in that way, this will be the better presentation. I think so. Okay, anything else? But good point. But later on, in a case of suppose rheumatic fever, the sore throat nobody knows, nobody remembers, right? But when you are thinking that it's a rheumatic problem, and if you ask them, then they will show you in the paper that yes, I have taken the treatment from the family physician. And then you can correlate that yes, the sore throat was there, tonsillitis was there, likely the streptococcal, and probably the same story has a late complication, it has presented like this. So that link you do later on, not from the beginning. And therefore such points as a previous illness, as a part of problem or complication, what disease develop, that link you can try to establish later on. So I think here it is at the right. Okay, anything else? These are the good points. I think it will help you a lot in the exam, that how you should put it. Anything else? What type of these support diarrhea, which infections are or which organisms are known to link with this type of the weakness of the GBS like picture? Which organisms are common?
Campylobacter
Campylobacter
jejuni.
jejuni, sir.
Campylobacter.
Okay.
Campylobacter.
Anything else? Now the people are suspected so many.
Mycoplasma.
Okay, occasionally, but mycoplasma may come with the respiratory, but okay, mycoplasma. Even enteroviruses.
How?
And enteroviruses will cause this diarrhea.
Coxsackie.
And respiratory infections also you should keep in mind, mycoplasma and other things. Anyway, how these infections are linked up with this problem? How they are important? Yes, Dr. Aarti? How this history of mycoplasma or some respiratory infections or some GI infections and correlating with the development of the weakness or GBS? What is the link? What is the explanation?
So they behave as antigens and molecular mimicry concept is there.
Okay, that's good, Dr. Manika. Then why you are not participating actually, keeping your video on?
Sir, actually my network is not that good.
Okay,
so
because I want to know the students. Nowadays in our postgraduate clinic also what happens that more numbers of the students, so it's difficult. Years back I remember in 85, some 15 students by name even. And somebody is not driving the scooter appropriately, that also I will notice beside the clinical even discussion. So I think that's the thing that I want to know the student. And probably it may be the beneficial, it is possible that Dr. Manjeer or myself or even anybody can come as an examiner. So at least we'll come to know that you are answering properly. So take the benefits of all the teachers. I think Dr. Nisha is also there, right? So in a lighter, I will say no time talking, but this is always that you should keep your video on. And presence of the person makes a difference. Anyway, I think who will give the first summary? Nowadays, that in the history examination, first summary is from the history, second by the examination, that what now you have come to the conclusion. And here with the history summary, that means you are preparing the hypothesis, that what is the likely problem with the child. Not necessarily you will be able to go with the diagnosis. Most of the times we are not able to even diagnose. But of course you have some ideas that this is a likely hypothesis, this is a likely pathology. And in that way, you can keep you on the various possibilities that these are the various conditions which can present in this way. So who will prepare it? And for this, always go for the multiple times exercise in your daily round. Such a case, I will say write down on the paper, some 10-15 lines. And the summary is not the repetition of the same story what Dr. Sayan has described. Past history, birth history, development, normal, not like that. You focus at what's the presentation, how you are taking it, what is the likely hypothesis, right? Here I think it's a CNS problem or not. CNS which problem? Anatomy. You are trying to localize the anatomy. It's a central or a peripheral. Peripheral, then which part is likely? Accordingly, and then both conditions are various. So try to prepare this hypothesis. Who will give the summary? And for this, I'm sure that unless you go for the multiple times exercises, naturally nobody can speak immediately. But at least make the attempt over here. I want the attempts from various students. Who will voluntarily? Who will
Acute
do?
onset. It
Very
is
good,
acute.
Anna. Yes.
It is acute onset, which has progressed over hours to 1 day maximum, and it is ascending paralysis, first involving the lower limb and progressing, and the progress is also very rapid. That it has involved the respiratory muscles and bulbar weakness is also there, and this has been associated with a it is in a child who has been born from a non-consanguineous marriage with a not significant birth history or developmental issues, and this child had also gives also a history of a diarrheal episodes almost 2 weeks back, and a similar episode occurring almost 2 or 3 months back, which required admission in ICU and IV medications. So, as it is not involved with tightening or anything, I would think the anatomical localization is in the below the spinal cord, and it is an acute process, not hyperacute, mostly not vascular. So, and there is no ingestion of toxins or any bite or anything, so it is mostly an infectious or post-infectious cause producing the weakness, and with the only comorbidity being weakness. There is no seizure or anything like that. So
Okay, I think good attempt. But that go for the multiple attempts. It should be like Gita. The whole story you should be able to say in the 5 sentences. I think everybody has listened the story. In the exam also, all the examiners said, listen your presentation. Then ultimately they want that what is your inference from this story. That's the point. What we say, what is in the nutshell. I think that should come in the few lines. But of course, it requires multiple exercises. Who will do one more? Then we'll go further. One more student.
Sir, may I?
Yes, Mayur, very good.
Sir, 3-year-old male child which complained with inability to walk, which was of sudden and progressive in nature and associated with loose motion since last 3 days, and no history of no history of affected consciousness, and no history of any trauma, and past history, similar episodes of past history 1 year ago, which received some medications, and no history of any trauma or consciousness or any other significant association other than GI symptom involvement, sir.
Okay. I think in the short, how we can try very shortly. We can say that a 3-year-old female child has presented, and from the whole story, I'm thinking that whatever it is, probably it is the nervous system problem. It is more likely the peripheral involvement of the peripheral nervous system, which has started acutely, but it is very rapidly progressive, and it is in the ascending pattern. And even having this respiratory involvement, which require even the ventilatory support. Rest of the points, I think it becomes very clear. With the history of diarrhea, if we try to correlate, that probably the post-infective, some autoimmune disorder is more likely, which has involved the peripheral nervous system. In the peripheral nervous system, it is bilateral symmetrical. It is not patchy or asymmetrical. From that, the many points you can convey. And without the involvement of even the cranial nerves or other aspects. And I think that story indicates that it is more likely peripheral nerve problem. And if the peripheral nerve problem, when the traumatic and metabolic and other causes are not obvious, probably it should be post-infective, demyelinating or post-inflammatory. And having these probably most common conditions I would like to keep in mind. And that may be in the form of the GBS also. I think acute transverse myelitis and poliomyelitis I would like to keep in the DD. But now still poliomyelitis is so rare. But still on the country, at the point which we have reached in our country, I will not leave it. I should keep in mind, because OPV and other vaccines are given, and post OPV, even these problems are known. And they can now present in any form, so that I cannot exclude it. Having this other presentation, if you keep it, I'm sure that the people will consider it, right? Okay. I think as you put it in a multiple times, of course, there will be the good improvement, and that will be the very impressive in the exam. So I request all the students that prepare it, even present it, tell your teacher that please listen to me. I have prepared this my summary. And I'm sure that it will make difference in your performance. Sir, am I right, Dr.
Yes.
Should we go for the examination? Okay, Dr. San, you can share your PPT and go for examination.
In my examination, sir, shall I attempt to once that summary part?
I think already that we have discussed.
Okay.
Okay.
Okay, sir. In examination, sir, with consent in a well-lighted room, the child was examined. Child is oriented and cooperative. Child was lying on bed with hands by the side, partially extended at elbow with palms facing up and both the lower limbs extended at knee, abducted at hip and lateral aspect of feet touching the couch. Child had IV line in the left hand and there was no signs of palar icterus, cyanosis, clubbing or lymphadenopathy. In the vitals, sir, pulse rate was 94 per minute, regular in rhythm, well palpated on right radial artery. BP was, blood pressure was 100/70 in the right upper limb in supine posture, which is between the 50th to 90th centile in right forearm. Respiratory system in 26 per minute respiratory rate with thoracotypic respiration. Temperature was normal, 98° Fahrenheit right axilla. SpO2 was also maintaining on room air.
Okay, go ahead.
In the anthro, so there is no gross deviation as per the age and height and weight. As per the age, the child was normal, sir.
Okay.
Head to toe examination, no significant abnormality detected. Skull hair normal. Eyes, there is no ptosis, no evidence of vitamin deficiency, no evidence of any neurodegenerations, no skin rash. Spine and back appears normal, sir. Higher mental functions, sir. Child seems alert, oriented to time, place, and person. She was interacting well with good immediate, recent, and remote memory. Speech was normal. In the cranial nerve examination, sir, I have examined optic nerve, which appears normal. Third, fourth, and sixth nerves, sir, there is no ptosis, no extraocular muscle involvement. In the trigeminal nerve, sir, it appears normal. Facial nerve also, sir, normal. No deviation of any gross deviation was present. Gag reflex was present. Uvula in the midline. Glossopharyngeal vagus was intact. Hypoglossy was able to put to the tongue and there was no gross deviation. In the motor examination, bulk bilateral equal on both sides. There is hypotonia in all four limbs. Power, sir, upper limb 3/5, both side, right and left, and the lower limb, sir, only flickering was present, 1/5. Superficial reflexes were mostly present, sir. Abdominal reflex was absent. Conjunctival corneal was present. Plantar, no response was there, sir. Deep tendon reflexes are biceps, triceps supinator, bilateral 1+, knee absent, and ankle bilateral absent, sir. Sensory systems are able to perceive touch, pain, and temperature on all over the body. No such sensory level was detected. Joint sense, position sense, and vibration sense was perceived normally on sides. In the cerebellum, sir, grossly normal. For the sake of the presentation, I have mentioned, but grossly normal, sir. No meningeal signs was present, no signs of any raised ICT, spine, no tenderness, no signs of any autonomic instability, bowel bladder were intact, gait could not be tested. Other systemic examination, sir, normal. GBS, there was no such gross sounds. Respiratory is also respiration wise are improved, no such findings. Parabdomen also normal.
Okay, can you stop sharing? I think who will interpret these vitals? Interpretation of the vitals. Any comment from any other student? If I remind you, as mentioned, pulse 94, which I have written, regular rhythm, blood pressure 100/70, respiration. I think, Dr. San, on which day you have examined the patient?
On the 12th day of admission, sir.
So I think that you should mention.
Yes, sir, mentioned. I mentioned in that previous slide.
Because these findings should be changed totally. So at least that you should mention. Okay. What does it make difference in the mentioning that pulse is regular rhythm? Dr. Isha, what is the importance in this patient? I think routinely you will mention, I understand, but very specific for this patient.
So, because in this case, from the preliminary history and examination, it looks like we are dealing with a case of lower motor neuron paralysis, maybe GBS etiology. So that can also present with autonomic disturbances as a complication to it.
Right.
So for that, the patient can have disturbances in the blood pressure, can do tachycardia, bradycardia. So we need to monitor that.
Oh, just that's the point. And SpO2 had mentioned 94. Is it normal or abnormal? How will you take it? In the room air, 94.
Room air 94. Sir, that's fine.
Fine means
So
normal.
ideally 95 to 98.
I will say the way in which you are expressing, you are not happy. So what does it indicate? You said, okay, sir, fine. I think it's not fine.
Sir, my target saturation would be between 96 to 90%.
I think.
So if it is 94,
okay. Any other person have the comment on the SpO2 94? With the reference to our patient we are talking.
Sir,
or in other way, I will take it. Suppose in the OPD you are sitting and some other patient is brought to you with respiratory problem or some other problem, and SpO2 is 94. What you will do? You will say it is okay. Isha, what you will do?
Sir, I would like
even your
nursing, the child further.
Your nursing staff say that the 4 times I measured, constantly weighted, but it comes to only 94. Now what you will do?
Sir, I would like to examine the child further.
Okay, you examine. It's not the CNS case I am talking. What Sayan has brought.
So if it is 90 to 94, then we have to repeat after 1 hour.
Okay.
1 hour.
Monica, what is your idea?
Sir, if the saturation, if we are not talking about CNS, then either it can be respiratory.
Suppose I will say it's a case of bronchiolitis. You examine that it's a case of the bronchiolitis, and somehow the SpO2 comes to 94.
So then we can go for repeat saturation after 1 hour, and if it is improved, if it is more than equal to 95%.
What you are expecting in 1 hour in a case of bronchiolitis, you are expecting there will be the improvement?
No, sir.
So what your idea of waiting? Whenever we say, suppose in a standard management of bronchial asthma, that after giving this acute patient comes, right, you give the broncho and you will see the response, and then you will decide whether to hospitalize or to send at home. So that protocol is set. Here, after waiting for 1 hour, what is your idea? And therefore I say, whatever we speak, we should have the justification.
Sir,
Right.
considering more than 92% on room air is fine,
But
sir.
Mayur always, even another point I will say, the exam also address the question. Don't deviate from the question. I said it's a bronchiolitis. It's a 94. The point is, parents say that write down the medicine. We want to go at home. What you will do?
Sir, in bronchiolitis case, SpO2 at around 92 or less than 92 may require O2 support. However, we can send patient on oral medication and can ask for follow-up if they are insisting them.
This is the point. That's why I asked. Don't send this patient at home. Don't send the patient at home. How you could even predict that 94th bronchiolitis is going to improve? On the contrary, very much chances that the patient may deteriorate, may not even, may deteriorate, but that you cannot advise to go at home. Hospitalize this patient. Of course, probably action of the oxygen therapy, as you say, for that, it goes if it below 92, you will go for that. Why I'm asking this question, in the exams, whatever the points you have prepared, examiners may not ask. You have come with full preparations of GBS. I will not ask a single question on GBS in the exam. Because I want to assess that whether as a general pediatrician, are you prepared or not? And for that reason, here the point is, and whether you have worked in the ward or not, you have tackled this emergency or not. And therefore such patients should be hospitalized. Very likely that they may go for the deterioration. By chance, if they improve, well and good. Here I will say in this patient 94, you will not do anything because it's in the recovery phase. Patient was in respiratory failure. You have given respiratory support. From that step, gradually patient is going for the improvement. And now the respiratory muscles must be developing the tone. And therefore the respiration gradually improving. And still the patient you are monitoring. So I will not be in hurry to do anything, just I will watch. And most of the patients go for the recovery. Therefore the 94 is all right in this patient. I will not go for any action. The point is, I think you should have the very good explanation and justification according to the situation. Right. So that was my point. One point I asked that all other students are there, they will note it. What Dr. Sayanaj miss in history in examination? Something is missing and which is very important. Which I will say even most of the examiners may not allow and I may not allow at all. That's a very important point. Whatever the condition it is, you should go with this in your examination. Growth chart. Right? Growth chart is missing. And I think it is very important tool for any pediatrician, whatever the system it is. In the exam, at least suppose if you have not drawn, at least show the growth chart to the examiner. So examiner will come to know that, okay, you are familiar with the growth chart, But the growth chart has to be there. That's very important. Right. I think and not I will say only for this passing the exam. In our daily practice, perform the habit that without the growth chart, you are restless to see the patient. I can't see the patient. Answer like that. And I'm sure that then you will do many things simply from the growth chart. Right. I'm sure. I think CNS examination, sir, I want that both of you. Dr. Mandir, can you take it? Whatever he has presented, for the sake of our learning, you can, how they should do what they have done. Please test. And later on even Madam can also add. Dr. Chandana. Do you want to see his presentation? Suppose if you are not
No.
able to recollect.
No.
Okay, sir.
So rightly you have given them, you have pointed out this, the vitals and other way, that is very important. And the respirations in the, you have forgotten about whether there is a distress there or not there. They have been looked after them at me, and that can be seen. And what are the things you would like to see for a distress, whether the child is in distress or not?
Yes, sir. Very, very important, sir. Who will answer? Yes, yes, sir.
That's important to be there.
With George just simply ask you to with respiratory distress, you should note it. And what other points you will
Work
note
of
in any case of respiration? Yes, Dr. Anna.
Retractions, nasal flaring.
Use of accessory
work
muscles.
of breathing. Work
Use
of
of accessory
breathing.
muscles.
No.
Respiratory rate.
Respiratory rate is
Subcostal,
there.
intercostal retractions, sir. Any work of breathing, pattern of
But how will you see the
respiration.
work of the breathing on that?
Retractions and
Use of
nasal
accessory
flaring.
muscles.
Retraction is
Nasal
important. Nasal movement is there.
Nasal,
Subcostal
nasal
muscles is
flaring.
very important. That's the nasal flaring is important because whenever we look after them, they are might be wearing a clothes and all, and you will be missing. It is very important to see in a as a whole.
Exports check.
Then respiration is important. You have taken this temperature, not the feeling febrile and other way around. You should be very. When will you say febrile child? What should be the temperature at which you will say is a febrile child?
More than 100.4 degree Fahrenheit.
So what is the normal temperature then?
97.7 to
8.4 degree Fahrenheit
99.5.
auxiliary temperature.
98.4.
98 point. So febrile child ke liye you have to tell about 100 degree. Otherwise the child will not be the febrile. Usually 99 point. Suppose if you take in the 99.5, they can consider. Probably this will be. So temperature is also play important role. This blood pressure was within normal limit. There was no problem on that way. You have taken this blood pressure. Oxygen saturation you have taken. Which side you have taken? Right side ductal and other way around. So oxygen saturation is important on that way. So this is a comprise of all things. Then you have other examination other you did on the apart from that. Any findings in the in the chest another way?
No, sir. No gross. No gross findings was there, sir.
No cross findings you have seen other way. So this is the vitals is important and that to be considered on that way, right? Then apart from that, you will like to give the systemic examination. So your examination will be confined to which place of that? Because this respiratory rate was 26. So is it a normal for this age?
3-year-old
3
3
years?
years normal.
Yes,
It's a
normal.
normal. 30 is
Normal.
a normal. 40 another way around if you happen to be earlier. Because 60, 50 and 40 is important on that. You should consider that. On that. And when you are
Less than
taking
1
less than
month
2 months.
up to 1 year and more than 1 year, sir.
1 year. So that's important to be there. So it's a
Yes.
normal temperature.
64, 50, 40. Oh, sir.
Oxygen saturation was normal. So this child appeared to be a respiratory systems are impaired. Any other thing, the subcostal and intercostal there was not there. Any Harrison circus, any other things are going on. Any things to be, what type of the breathing was there?
Thoracic.
Abdominal, thoracic, and thoracoabdominal.
Thoracoabdominal.
Thoracoabdominal, abdominal thoracic.
No,
Or
sir.
is it paradoxical? Or paradoxical? What is happening in the paradoxical respiration?
Paradoxical, sir, means mixture of both the respiration. It will
What
be
will happen to be clinically? How will you see that whether is a paradoxical respiration is there or not?
Outward movement.
What will happen to be the abdomen and what will happen to be the chest?
In the abdomen during inspiration, it should be full abdomen. The abdomen should rise during inspiration.
If it
It's
is there, it will
opposite,
be
it
very
is paradoxical.
opposite, sir.
Because this will also play, but in the case of this polyneuropathy and other way, we should be very careful in dealing with the situation, whether there is a diaphragm involvement is there or not in the costal. So these are all the vitals they will let you know. Then systemic, you will give the examinations on that. This is perfectly okay.
Okay. Sir, can you take it or Dr. Chandra, can you take it the CNS part? Madam?
Yes, sir. Yes. Yeah. Can you show me the CNS examination slides again?
Yes, ma'am.
Can you open the CNS examination slides? Yeah. Go to the motor system. Yeah. So how have you, so first you saw the higher mental functions. Go to the previous slide. The first slide of the CNS examination. Yeah, anthropometry, higher mental functions. So first you saw the higher mental functions. So that is okay. Next you saw the cranial nerves. Those are also okay.
Amen.
Yeah. Next. Yeah. So then you saw the bulk and the tone, which was hypotonic. Yeah. Next. Yeah. So according to you, the power of the upper limb was around 3/5 and the lower limb was 1/5. And the dorsiflexors and plantar flexor of foot was 1/5. So how did you assess the power of dorsiflexors and plantar flexors? The child would be lying in a supine position only, na, by the time when she had presented.
Yes, ma'am. Ma'am,
So
just making the child to left lateral position.
yeah, so here in this case, since the power is 1/5 only, you will just say that he was only
Flickering was only present
in any position. So that's why I'm saying that dorsiflexus and plantar flexus was 1/5 and the rest of the muscles were 3/5 and 1/5 or whatever. Yeah, and next power, after power, reflexes. So this was a girl, no? Okay, but if it would have been a boy,
Cremastic
reflex
reflex.
was also important. Yeah,
Yes,
next.
Deep tendon reflexes.
Deep tendon reflexes were depressed for this child. Okay, next.
Sensory system.
Sensory was okay.
No
Next.
sensory. Cerebellum.
Cerebellum was also okay. So were you able to do all these tests? So you could not. No intention.
No, ma'am. I mentioned I could not able to do it.
Next.
For the sake of the presentation, I just mentioned.
Yeah. So no meningeal signs you want to say, but this child must be intubated when this child had presented. According to you, you had told, na, she had presented in respiratory failure, and
Yes,
she was. So was she conscious enough for you to do these meningeal signs?
No, that was on the 12th day of admission, ma'am, when the patient was shifted to ward and completely out of venti and all on the room here, ma'am.
Okay, at the examination findings are of that time. Okay, so meningeal signs are important in GBS, na? So what do you expect for meningeal signs in GBS?
Ma'am, it's to differentiate between, ma'am, from polio, because there may be neck rigidity may be present, ma'am, in case of polio also, ma'am.
Yes.
In
So
apparent and abortive.
in GBS, are meningeal signs present or not present?
Can be present,
GBS, ma'am, can be
Can be
present
present.
if the cranial nerves may be involved.
No. So why are
Radiculopathy.
It's
a radiculopathy.
Radiculopathy.
Yeah. So GBS is a radiculopathy. But what do you mean by meningeal signs?
Ma'am, neck stiffness.
Yeah. So what is the cause for meningeal signs? How does meningeal signs occur? So meningeal signs are typically seen in what sort of illness results in meningeal signs?
In infections and
infections. Yes. So, but you are telling me that GBS can also have meningeal signs. So why are meningeal signs present in GBS? Or how do infectious etiologies result in meningeal signs? What is the pathophysiology behind meningeal signs?
Ma'am, there may be a focal degeneration or maybe, ma'am, segmental demyelination of the nerves, which can lead to meningeal signs, ma'am. Rarely, but maybe, ma'am.
So in GBS, what happens? Our dura and arachnoid matter, which is present around the spinal cord and which is present when which is present around the origin of the nerves, from where the nerves emerge from the spinal cord. These nerves are inflamed. Due to their inflammation, the overlying meninges are also inflamed. That is why sometimes we get meningeal signs in GBS. Okay, so this is important. Meningeal signs are important. When we get meningeal signs, it's a soft marker that the underlying illness could be a GBS. Although when we are getting meningeal signs, first and foremost is an infectious etiology for which we have to work up. Okay, so this is it. Sir, apart from this, I think the rest of the exam is taken care of.
Can you stop sharing?
Yes, sir.
I think now the examination is also given. Anybody can enumerate the positive findings. Why I want, any CNS case, please keep in mind that how you should try to approach. Number one, always ask the questions to yourself. Generally, I'm talking, not in this patient. that is it CNS case or some CNS mimicking condition? I think the first question you should be asking like this. Second, once you decide the CNS, I think the history and examination try to decide that where is the anatomy. I think not only in CNS, more so in the CNS, always ask the question to decide the anatomy. Probably anatomy will be more clear from the examination. That even the suppose central nervous system, which part of the central nervous system? With cortical involvement? Is it a coronary radiata? Is it midbrain, pons, medulla, and every component is having the very characteristic of presentation from which you can make out, which many a times even in this modern era of CT MRI you may not get it, but yes, you can get in your clinical examination. So I think it's very important. From this anatomy, try to decide that what is the likely pathology. Is it really infection, non-infection, vascular, degenerative, traumatic, SOL, so many things, neurometabolic, and every component again is the very characteristic history and examination. So try to define that what is the pathology. And from that, what is the likely etiology? And that etiology, suppose meningitis. If it is acute, you can say bacterial meningitis. Even according to the age, you can say that this is likely organism. Why we are going for this exercise? In the absence of the laboratory evidence, your choice of treatment should be very appropriate. This is not just for academic discussion or not just for, I will say, passing the exam or showing our ability. It is, I will say, ability to manage the patient very appropriately. And I think for that reason, all of us should always try to perform this habit. It pays a lot. Even in this era of the modern gadgets, of course, the modern gadgets have added a lot, but I think it should not be the cost of clinical examination. And you must be knowing, please remember, it is said that 80% of the CNS evaluation is almost from the history. Almost from the history. Examination is to confirm my finding, that what I'm expecting, is it there or not? And afterwards, I will say investigation is just for confirmation labeling or excluding something which may be sometimes surprise to us. So the point is never give much importance to the investigation in spite of easily availability. Of course, these modern things have added a lot in our understanding. So keep this, I would say, this type of the approach. Suppose here in this patient, if we try to localize, Dr. Mayur, can you take it? That where is the anatomy? Which part of the nervous system is affected? I think in the short you can go.
Sir, it's a weakness is ascending paralysis, so it's mostly.
No, I think let me ask you the very precise question so that you can answer and we can save the time. Is it CNS problem or peripheral nervous system?
Peripheral nervous system.
Peripheral nervous system.
Okay, I think what will be the characteristic of central nervous system in some other case, Dr. Anna, where you can say that yes, this is a central problem.
Cortical signs like aphasia, seizures, loss of consciousness, all these things are not there in this case. And if we come lower down in the brainstem,
I think I am not asking in this case as a whole for understanding. Central nervous system commonly altered sensorium.
Yes,
there are functions in the form of the speech, maybe in the form of the memory. Seizures are most common presentation, or I will say manifestation of this central nervous system. Speech disorder. So I think from this you can understand most of the times. Okay, suppose I will not go into all the details because it's very difficult. It is time taking, but still, suppose if it is peripheral nervous system, it can be anterior horn cell problem. It can be peripheral nerve problem. It can be neuromuscular problem. It can be even the muscles involvement. Now, who will take the characteristic of each component from which you can say that yes, this is the anterior horn cell problem, or this is something else.
Anterior horn cell is an exclusively motor weakness will be there without any sensory involvement. And in case of neuropathy, there will be a mixed involvement of sensory.
I think go one by one. First characteristic of anterior horn cell. This is
Anterior
good for
horn
us
cell,
to learn even.
it is pure motor weakness, and reflexes may be present, and there will be no sensory involvement.
Why the reflexes will be present? It is lower motor neuron type.
Sorry, reflexes are absent. Reflexes are absent. Pure motor weakness with.
I think most of the other manifestations will be similar, but can you say one characteristic?
Fasciculations will be there.
Absolutely, very good. If you get the fasciculation, that will aid you. Can you give now one example which you can remember? This is the anterior horn cell disease, so that you
Spinal
can
muscular atrophy, spinal muscular atrophy, poliomyelitis.
Yeah, we used to remember poliomyelitis, but now you can remember the spinal muscular atrophy. Okay. Now, second, suppose the peripheral nerve problem. What will be the presentation of peripheral nerve problem? Etiology problem, pathology may be anything. We are not concerned. I want to decide whether the peripheral nerves are involved or not. What are the features?
Flaccid paralysis.
One by one person. I'm really happy that the multiple students are speaking. Otherwise, it's very difficult to make them speak even. Okay, I think Manika, you can continue.
So there will be hypotonia, there will be areflexia, neural involvement can be found, sensory features can be present, and the Ada bowel involvement, autonomic instability can be present.
You know how then I will be able to differentiate, because these features will be any type of the peripheral nerve problem. You know, that's always what we ask, how it started, how they start. Peripheral nerve problem involvement starts from where? Peripheral. Distal. That's why gloves and stocked appearance, what we say. And therefore, what will be the complaint? Many a times, simple complaint that they are not able to even to maintain the sleeper in the food. It sleeps away. Buttoning, unbuttoning becomes difficult. That gives the idea that yes, this is peripheral nerve problem. You know, any disease when progresses, it is equal. But how it started, that will give the idea. That usually starting from distally and then gradually progressive. Etiology may be anything. Suppose muscles, how the muscle involvement starts.
Proximal weakness.
Proximal
weakness. You know how the patient will complain. Difficulty in getting up.
Combing the hair.
Difficulty in climbing the staircase.
Upstairs and down.
This will be the problem. Combing the hair, removing the shirt, because you know it requires the shoulder to uplift. So listen to the complaints. That will give the idea that yes, it is muscle problem, whatever it is, right? And that will be the very characteristic features. Anterior horn cell, peripheral, myasthenia gravis already we discussed. He complains of fatigability. That is the main complaint. And otherwise he is fine in the morning. With the energy, he is fine. With the loss of energy, he goes, I will say, weak. And this vision problem of phenoplegia, so many disturbances with it. This is just to give the idea to all the students that we should have this approach. And that will give the very clearly, distinctly picture in your mind. I think here, if you see in this patient, it becomes very clear that yes, it's peripheral nerve. Then ascending, descending, so many ways you can think regarding the disease process and you can locate it. So first anatomy, which was my point, then the pathology and like that. I think here in this patient, if you go for finding central nervous system, cranial nerves normal, right? Particular motor system, hypotonia, power is affected, areflexia, very classically lower motor neuron type of lesion. Right. Second thing you can say it is bilateral symmetrical. It is ascending. Now, why it is? Who will qualify that issue the GBS? Suppose if your diagnosis is GBS, how will you qualify? How will you convince me? Who will try to explain me? I think now everything we have discussed. Everything we have discussed. Then we'll go for the further advancement or something unusual from the experts. But who will explain to convince me that yes, it is the GPS?
It is
Okay,
ascending,
Sir,
okay.
it is hypotonic, it is areflexic, and it is bilateral and symmetrical. All the
yes.
criteria, and there is progression and the acute onset, and also the relation with the diarrheal episode. And also there is no bowel or bladder involvement presently, and sensory involvement is not there.
Not there.
Less sensory involvement. Sorry, sensory involvement is there. It can be there in GBS also,
Yes,
if it is
yes, sir.
answer and variety, or in that there is sensory involvement also. So all
I
this
think
point, and there is
anybody can comment on the progress of the disease, which can convince me. What will the pattern of progress in a case of GPS?
distal to proximal progression was there,
No,
and distal
course.
thickness
I
is
would say course of the disease. Course of the disease. I think most of the
improved
points
with
what Dr.
titration.
Anna said and we have discussed, that it is bilateral symmetrical, lower motor neuron type of lesion. It is ascending pattern, right? And most of the points otherwise what she mentioned, that is middle bone involvement and cranial nerves and other things are not there. Okay, they are helping. But
Sir,
which will be very, very classical, you can say that this is kind of course of the disease. Course will be acute, right?
Rapidly progressive.
And then it becomes plateau. Then for some time becomes a static. And then gradually goes for the recovery. Now look at your patient. Presented very acutely, very progressive, required the ventilator support, catastrophic like storm. Fortunately, patient came out. Now you can say that it is a recovery, right? Remain for probably progressive static, must be on the ventilator or so, that later on deteriorated. That's why improved. And now the patient is in the phase of recovery. This course retrospectively convinces you that yes, this is more pattern of this GPS. Now with this question, I think let us go to the experts, because I'm sure the students may not be knowing. When you will suspect that it looks like GPS, but it's not the GPS. Sir, can you take it?
Sir,
Yes, sir.
before this, three things must be kept in mind. You have
Yeah,
very
please, you can
you have
add.
elaborated, but as a student, they will care. Because whenever we give the CNS diagnosis, as sir told, pathology and all, think three things: clinical, anatomical, and etiological. This is very important, that you have to be very careful. So clinically, what you are getting, and try to do the anatomically where it is going. That this is important. Now the question arises: this as a case we have discussed about the GB syndrome. It is a viral in origin. It's a demyelinating disease. A lot of things are people are not aware of it, but usually an autoimmune disease is there on that. And basically, you see the peripheral neuropathy. If there is a nerves are involved, so it involves the both. It is not only this involve the motor, but it also involves the sensory. So that can happen to be. This will very clear in mind. This child developed the problem with the tingling sensation. This is another manifestation. You should be very careful, because sometimes mothers explain, and even after 2 days, the child comes to you with the paralysis. So it should not be kept as such. And we have missed a lot of cases, usually missed in the OPD. If my parents are telling about you that this child has got some problem, chiti katra or other way the tingling, but we should always be careful in that. Now the question arises whether this is only because of the bacterial. Of course, it is a bacterial, maybe, but not is a bacterial, is a viral is also in origin. Sometimes precipitate, not a viral. If you anybody asks, you can say that it's not a only the etiology is viral and other way around. It is autoimmune, no doubt about it. Demyelination occurs, but it is happened to be there. As far as concerned, this case is viral in origin and LB. Even during COVID, people are getting a increased precipitation of that happened.
Yes, yes.
HIV, that can be a presentation will be there. Sometimes we miss it. We must look into them. Something is wrong with that on the way. Then apart from that, I told you this recovery state. You see this the recovery is also play important role, or because parents are much more interested what will happen to my child, and you have to give the answer to them. The most important usually is said, and the book says whether it is a 80% or a 60%. Usually 80 to 60% the recovery occurs, but how much it will happen a day. They will ask a lot of things about the what type of food to be given on that. whether exercise, what type of exercise to be given to them. So if you ask them anything, the exercise, usually aerobic exercise play important role on that. Food, it is said to be that usually the high content of sugar to be avoided. Why it has happened, nobody knows about that. Treatment is also be given. Is it a pure treatment? Is there curative? Answer is no. It is we are trying to give the immunoglobulins. And immunoglobulins, they help us. So we cannot say it cure this, but it is somehow they improve this. So there is no specific treatment of that. Sometimes these people have the exams and other, they ask which investigations, if you want to diagnose, which investigations you would like to do, and when will you like to do? So of course, CSF and all will play important role. You should be very clear in that what is going to be happen. So CSF examination is an important. You look into them. But here we find out that investigations are not meant for the diagnosis. Investigations are only for the three prongs. Number one, what is your hypothesis? If it is there, is it not? Second is what is the extent of damage? And the third is what is the modification of the treatment? You can do that. These are the only three reasons we need that. People think that you would build the MRI, CAT scan, and you will get a lot of things right. Absolutely wrong on that. So as such, for a patient, they will always ask you that what will happen by the child prognosis, what will be happen to be there, whether it will recurrence will be occur or not, it should also be given the way, and when will be recovery will be there. And hope this is a recovery is better on that. Immunoglobulins we are giving them, it's a very, very costly. We should also look them whether they are able to do that. Sometimes you are given one doses and second doses, the majority of them they are not given, then it will be. So you think on that, we kept in mind. So these are all the things points presented very nicely. Then it will be. You taught us a lot of things, and also taught from the Prajapati sir also taught us and enlightened us a lot. Thank you very much, sir.
Thank you, sir.
So
Thank
it's
you.
very, very important. Very nice. And
I
very
think,
interactive. Very interactive.
yeah, very interactive. Students are also very interactive.
Very
we are happy. Yeah.
So I must appreciate them that
Yes.
they have to be interactive.
I think the students, what I want to remind you, you must be aware that recently the Gujarat University exam is going on. I'm sure at other places also must be on the
Everywhere.
process. Yeah. And if you look at probably, if you ask your friends, even one of the cases which was common in the long case was the GBS, but easily available, and therefore, and even common condition or practice also. So we should know, and I think every point is very important. Suppose somebody asks that when you should do the CSF and what is the importance of CSF in a case of GPS?
Yeah.
Yes, Dr. Manika, can you take it?
So within 48 hours, within 48 hours maximum, we can do up to second week of illness.
I will say don't look at your expert friend because Sayan is nodding the head. And the same thing happens in the exam. You know, always expert is behind you and the student is looking at the expert. Which I don't know how the definition or terminology expert had derived because he has to pass the exam, but still we say expert. I think expert to manage the situation, but not like that. Monica said that within 48 hours or after 48 hours or within 48 hours. What was your answer?
So within 48 hours.
Okay, this is one, I would say, MCQ answer. Chinmay, what will be your answer?
Same, sir, within 48 hours.
Within 48 hours, very nice. Sagrika, what you will do?
After 48 hours.
Okay, Anna said after 48 hours because I want to create this, I would say, debate among the students. You know, there is also another way of even learning and teaching. Sagrika, what you will do? Suppose if you are on call, then you will advise. Unmute yourself.
Whenever there is a confusion between meningitis and GPS.
Okay, I think here it is not confusion. The way in which he has described the case, it looks more likely GBS or at least peripheral neuropathy. Probably it is not the meningitis. Anyway, Esha, what you will do? I think this was not in my mind, but now I recall. I thought that it's a good question which I asked. I thought on the contrary, everybody will answer. Isha, what you will do? You are on call. Unmute yourself. Unmute yourself. You are muted.
So I
Isha,
would like to do it within 48 hours. Hello? Hello?
within 48
Hello?
hours.
Yes,
Yeah,
sir.
yeah,
I
yes,
would
yes.
like.
I think let us ask the expert. Madam, Dr. Chandra, what you will teach and what is the idea that the timing is also of CSF examination is very important. And many times it happens the same thing what you did. You have done the CSF and you say it is normal. Every time this round we say that sir CSF is normal. And then really this is the problem that why you are getting the thing. You know, serum Vidal is done on the third day and we say that Vidal is negative. Therefore it is not entering. But when the Vidal should be done, that we should know that Vidal should be done after 7 days of the fever. So similarly, let us learn from Madam. Madam, what exact time and what is the idea?
Sir, so basically what is said that CSF abnormalities appear after 48 hours of onset of symptoms. And they may be normal till 7 days of the onset of symptoms.
Yeah.
So in the first week, even if we are getting a normal CSF, that does not prove that our diagnosis, that does not exclude GBS.
Exclude.
So we should prefer to do CSF at least after 48 hours of the onset of symptoms. Only thing is that sometimes after giving IVIG, CSF picture may change. So better to do it off before and prove that it's a normal CSF, especially if meningeal signs are present. But we must not exclude GBS just on the basis that CSF is normal, especially in the first week of illness and especially in the first 48 hours. And same for the nerve conduction studies also.
And second question with the reference to Yesha, as Madam said, I think please remember, earlier done the CSF, maybe even the normal, may not help you to catch the GBS and does not exclude it. So please remember. And many times Madam said up to 7 days, yes. And therefore, probably earlier if you have done, you should keep in mind that my CSF was early. Therefore, may be normal. If you get it, I think suppose some pleocytosis, okay, it helps you on it. Now, what is the CSF picture in a case of GBS Asia? And what is the explanation?
Sir, in GBS, we have a picture of albuminocytological dissociation, wherein the cell count might be normal, but then we have elevated protein in the CSF.
Okay, why it happens so? What is the mechanism? What is the explanation?
So that is attributed to the inflammatory and post-infective processes that has occurred.
Isha, if it is infective, Isha, if it is inflammatory, I think cellular reaction should be there. Am I right? Commonly what we say that inflammatory reaction, cellular reaction should be there. But here cellular reaction is not there and protein is rising. So what is the explanation? I think some student is having the good scoring that these questions may come. Yes, yes, Dr. Sayan is raising
Sir,
the hand. Yes.
this is rather than it's not infection condition, sir, it's a immunological condition, sir. It is means it's beyond it's affecting the myelin sheet, sir. Whatever, sir, that chemicals is going on, this is affecting myelin sheet of the.
If I remind you, ATM is the example of again the demyelination. What happens in the CSF picture? You get some, may not be high, but yes, cellular reaction is there.
Yes.
So why it is differing in the GPS?
Sir, so I would like to try.
Yes, sir, Chinmay, please. Everybody should answer. No problem. Ultimately, we are the expert. I am confident that I am also not in tension. Hello.
Sir, in GBS, it is an inflammatory condition. So at the site of CSF production, there would be ultrafiltration of the proteins into the CSF more as compared to the normal subject.
Can you explain me, you know, from this, what I understand as an examiner, that Chinmay has read. He is having some idea, but difficult to explain. Can you explain me what is the ultrafiltration, from where it goes, and albumin is going, then why not the cells are going? Can you explain me? Your point
So,
is, I will
sir,
say to some extent you are right. You have some idea, but you will have to explain me.
so due to the inflammatory processes, it happens that when the CSF is being formed from the blood plasma, the proteins from the blood plasma are more likely in a greater quantity able to pass through the sieve-like mechanism.
Madam, can
and
you
enter.
take that point, please? Can you take that point? I think we have some time. We will utilize the time maximum for your questions and an exam point of view. Madam, just you can
So
explain.
the cause for increased proteins is attributed to the breakdown of and the involvement of the blood-brain barrier also secondary to inflammation. So one point is that, and other point is due to some demyelination which has occurred, that also increases protein. But I'm also not exactly sure, and I think the exact reason is still unclear as to why proteins are
Yeah.
elevated. But these are the two hypotheses which are put forward.
Absolutely, absolutely. What Madam said exactly, we are not sure. That point is valid. But one of the, I will say, good explanation which is offered, you know that these particularly the Madam was telling that peripheral nerves are also affected in the case of GBS and which are covered with even the dura and the arachnoid matter. Now with this inflammation and this autoimmune disorder, the blood-brain barrier is breached. And with that, there is the ultrafiltration, what you are telling Chinmay. I remember you have taken the word from that. That from the blood, yes, protein can enter. The permeability has increased. But the cell is not there. And from probably peripheral seat, the protein enters in the CSF and it is available. This is one of the explanation offered by most of the books and the neurologists. But I think that if you reach to this level, I'm sure that it is a good scoring in the exam. So no problem. I think treatment point of view, sir, what exactly plasmapheresis should be done or this immunoglobulin, and when we should go for repeat immunoglobulin, or when probably even both the things will require plasmapheresis and immunoglobulin. Just can you take that point? Dr. Manjir, sir?
Yes, sir. Basically, they say that the immunoglobulin should be given to be the as early as possible, since because if it is not given within 20 to 48 hours, it will be effect will be not very last. So it is very, very important that it should be given as early as possible. So the question arises whether we'll give the plasmapheresis or whether we give to the immunoglobulin. The still the randomized trials are still awaited. We go through that. We've gone through the literature. They have been sporadically, they say somewhere is improved with the plasmapheresis better than that, or some improve with the immunoglobulin. So the basic aim is that one should if upon the immunoglobulin because it is an autoimmune disease. So it may be a helpful rather than to be the. But
When this second dose of immunoglobulin, we may think.
This is a controversial, sir. Whether it should be given or whether it should not be given.
Right.
Usually they prefer to be given after the 72 hours. After 72 hours, but it may be given up to the 1 week or other.
And regarding the doses, some people, what we used to say 500 milligram per day for 4 days. Some people say even that in 2 days you can divide the dose. What you are following?
We are following the 2 days.
Right.
Yeah, 2 days we are following that. And the recovery is better, but it is 2 days.
Yeah. I think one question to the students, fortunately in this patient it was not there, but many times they present with the backache or pain is very severe in this patient. What is the cause for the pain?
Radiculopathy.
Okay.
Nerve root inflammation.
Okay, and suppose the pain is persistent to the patient, what we can do? Sometimes, it is not bearable.
Gabapentin can be given.
Gabapentin.
Pregabalin, gabapentin.
How the gabapentin works?
Calcium.
Gabapentin is GABA mimetic.
Calcium channel, sir. Gate
Calcium
control
channel.
calcium channel.
At least I'm happy that multiple
Fluoride channel.
students are offering the explanation. That's good. Otherwise, most of the time they don't speak at all. So this is good. I think, sir, many people prefer the steroids as an anti-inflammatory for this pain. Is it right? What is your experience or your recommendation? That it, it is due to the inflammation, that radiculopathy, root pain, and that inflammation many times does not subside in spite of immunoglobulin. And in that case, sometimes the people prefer the steroids. So what is your idea, Dr. Manjir, sir?
Sir, we prefer we release the paracetamol we used to give them.
Right.
Otherwise, that's the
Yeah, we may not go for the
but it's a sign of inflammation, sir. So probably because of edema and all, they can be a problem.
I think in one line you can remember that there is no much place of steroids in the management of GBS.
Yeah. But sir, we
I
should
think
be very
that we should be very clear for that.
clear.
Yeah, I think, sir, can you take it that looks like GBS, but when we should raise the doubt that some of the points from examination or history may not favor this diagnosis of GBS.
Yeah,
It may even turn out to be something else.
There will be other cause maybe there on that way, but we should always keep in mind in this whether it's only GBS. It should not perfectly. They say it's the GBS is only there, and if it is not improving on that.
So I think what we are commonly accustomed.
Apart from sir, they also prefer to give them some antibiotics.
Right.
And antibiotics usually prefer to be given to be a penicillin group of that. Some literature says it should be given maybe a bacterial sometime happen to be, but this is still controversial. And they are on the what you call authenticated, what you call the literatures are not available, but they prefer to give the antibiotic and all.
So I think suppose something is unusual, you can rather than ascending, it is a descending.
Descending, yes.
Even as occasionally descending GBS is also known, but descending then probably unusual. With the involvement of cranial nerves, probably some variant is there. So something you can keep in mind that this is not the common story of the GBS. I think last question, which I observed in this case also, because now Nehal has come and that is the signal that now it's a time for us around 8 o'clock. That's the, I understand. So that is the question, that what can be the many clinical pointers or these, I will say, prognosis of the patient. Many times we'll have to talk to the parents, or even as a clinician, from which you can predict that this is somewhat dangerous or more problems or complications in this group. Can you make out some situations? Anybody?
The need for mechanical ventilation.
Sorry?
Sir, IGRIS score, sir.
Need for mechanical ventilation.
Okay.
IGRIS score. Onset on the day when which the patient is presenting after the onset of weakness. If the patient is presenting early with the once the onset is there and presenting within 3 days of the weakness, that is a poor prognosis. Then bulbar involvement and respiratory paralysis is a poor prognosis. And then MRC grading we have to do. If the MRC grade of less than 20 is also again poor prognosis, because it might require mechanical ventilation.
At least I will say, from the general pediatrician point of view, please keep in mind, and now it is not uncommon, which even I have come across once in our unit few months back. Obesity is not, I will say, favoring point or more problems and complication rate with the GBS with the obesity. And particularly the adolescents, nowadays that they have the weight 50, 60s, more than 70 sometimes. And these boys, or I would say these patients, are difficult. And this one of the points which everybody has mentioned. Second, in the autonomic manifestations, in the form of the arrhythmia, in the form of the hypertension, I think these patients are again little bit difficult to manage and probably may go for more problems and complications. That I think we should be aware. And the third point, very important for the clinician, very rapid progress. Probably before you understand the GBS patient is on ventilator. And that type of the progress probably does not give the much time for the management, or may go for more rapid problems and complications. And I think some of the points which they have, I would say, under as a clinical markers, which probably we can keep in mind, or even the atypical GBS, not the common presentation, but somehow it is GBS. So I think these are the points which we can keep in mind. I think before we go for the wind up, anything, madam, from your side, Dr. Chandra?
Yes, sir.
Which,
So we had discussed regarding the use of second course of IVIG.
yeah.
So I wanted to add that there are no studies or guidelines regarding second dose of IVIG in children, but there was a randomized control trial which was done in adults as well as children population. It was published in Lancet in December 2020 or 21. So in that trial, when a subgroup analysis for children was done for that second course of IVIG, it was found that there were more incidents of adverse event as compared to benefit. So as of now, there is no evidence supporting the use of second course of IVIG for use in children. However, anecdotally off label, it is still used. Regarding 2 days and 5 days regime, so most often the logistics are involved, whether we can keep the child in PICU for 2 days and administer IVIG and shift to ward, or we have a PICU available that can keep the child for 5 days and all those things. But what is said in literature is that if we give IVIG for 5 days, the incidence of treatment related fluctuations are less. So literature supports the use of 5 days IVIG, but ultimately this is also what guidelines have just recommended. There is not clear-cut evidence that second day is 5 days better than 2 days. So ultimately logistics have to be taken in mind while we are giving these drugs. The third point which I wanted to say was, sometimes, so this child had presented with respiratory failure and everything. So we knew that IVIG was warranted in this child. But sometimes we, the severity would be only of, some difficulty in walking, or just some lower limb weakness with some falls. So will you administer IVIG in such cases? I will like to ask the PGs. So if a child has come to you with a 7-day history of lower limb weakness in the form of frequent falls, but the child is able to walk unaided, you examine the child, you find hypotonia and hyporeflexia, okay? And CSF and NCS studies are supporting the diagnosis of GBS. So will you give IVIG to this child, to such child?
First, I will like to go for MPS, pulse therapy MPS.
No,
GBS
diagnosis
no treatment.
If it is static, we avoid to give IVIG.
What is your cutoff for giving IVIG?
IVIG has
If there is
got
respiratory
either
paralysis,
respiratory involvement, bulbar palsy,
bulbar involvement,
or any
rapid progression.
Rapid
progression.
So if a child is not walking, but respiratory progression is not there, bulbar involvement is not there, you will not give?
But ma'am, if a child is not walking on duration of 1 week.
Yeah, so easy way is that
HDS score more than 3.
score of more than 3.
Yeah. So the easy way is, if a child is able to walk unaided for 10 meters, unaided walking for 10 meters, don't give IVIG. If he is not going to, if he is not able to do that, give IVIG. Why is it so? Why we should not give? We are giving for others. Why not to this set of children? So IVIG just decreases the severity and increases the velocity of improvement of symptoms. Okay. So it will decrease the duration of the illness, basically. But IVIG is not without its side effects. So if we know that the child is able to walk unaided for 10 meters, even if we don't give IVIG, that child is bound to improve. A child with respiratory weakness, even if we don't give IVIG, with supportive management, it will improve. But with IVIG, the duration of the weakness will be shortened. That is the reason.
I think fantastic point Madam has added. Very good, at least for all of us to remember. And it's a fact that even the GBS is a self-limiting mild disease without any treatment, can also go for recovery. I will say rather than I can quote, because it was not this, I will say, understanding, but many patients, at least 2, 3 patients I remember, may not be many. One even just before the COVID, I received a phone call from my resident that it is the GBS, we have done everything, but at very mild, and at least neurologist has seen and advised this immunoglobulin, but parents say that it is very costly, we are not ready, and please discharge us. We want the DAMA. So with this note, even the patient was discharged. After 6 months, they came that, sir, fortunately, child is all right. So I think, this is indirectly shows that in this mind, and as madam said, even after a few days, and when you see that what is the patient is able to manage, the point is every patient may not require, but it does not mean that don't go for this immunoglobulin, go for the exact criteria. And particularly in the era of the medical legal, you should be very clear in the documentation, right? So I think that is a very, very important message, but fantastic. I will say all the points what madam and sir have added. I think before that, I'm sure that whether the SAN has done or not, that may be the, I would say, scoring question in the exam, if I'm there, Dr. Sayan. And I'm sure that probably you have not done. And if you have done, you have not mentioned. I will ask I will ask the other students, in such a case, what is mandatory that we should do?
Single breath count.
Yes, Sagrika?
Single breath count.
Okay, I think that it is monitoring we discussed. No, in this patient, what is to be done? The patient has presented with a peripheral neuropathy. In short,
physiotherapy.
I'm not asking for the patient management. It is for the national program of this country.
AFP reporting.
Have you done AFP reporting?
Yes, sir. Yes.
That is very good. And then in the exam, suppose if you have done mention that AFP reporting is done, and that can be the again full question in the MD examination. Acute placid paralysis definition, and regarding its surveillance and even diagnostic criteria and everything, and which patient should be sent even for the AFP. Even isolated patient of palsy.
Yes.
That also should be done. And I think that criteria are there, even up to the 15 years. There's somebody asked that how it is done within 48 hours, I think they should go for the investigations. What is the authority should do? The stool samples.
Two stool samples, 48 hours.
I think at present 2 stool samples. Even after 60 days also, 60 or 90 days, you should go for
60
the
to 90 days mostly, sir.
Yeah, for the polio follow-up. So I think just I wanted to remind you, I may not be knowing all the criteria, but please you go through it. In such cases, it is mandatory. It is for every pediatrician to go for the AP surveillance, because our country has reached to the levels of polio free. We want to go for polio eradication. And all of you know that our neighboring countries are having this 70 poliomyelitis. And therefore we are, I will say, surrounded by them. So we should be very careful for the policy. And for the good AP surveillance, it is said, I don't remember, but minimum 1 case per 1 lakh or some ratio is there. It should be done for the surveillance. And good surveillance is a good policy for this polio eradication. And I'm sure that the pediatrician, medical person of this country, every medical person of this country, whatever the specialty, I think they should know, the general practitioner, AFP. Every, I will say, clinician should know the National Tuberculosis Elimination Program, because these are the demands of this country. And for that, I will say every medical person should be aware of it. And for that reason, these are the, I will say, hot topics for the exam questions. So I think that also you should keep in mind. Anyway, I think that's a point we'd have to, because we have overshooted, we to end over here. I would like to really, Dr. San, you have done the very good presentation. Very good presentation. On the contrary, I was asking all other students also, probably they are prepared for the MD examination. The way in which they were answering, but I will say multiple responses. I'm teaching at multiple places, but these are the responses are very few. So I will appreciate, that's good. even all other students, those who are, and I will even advise that as a learner, always remain in the front row, actively participate, whatever your understanding, even answer, respond, may not be right every time. It happens when, even both the experts quoted that still the science is not clear on every aspect. So it is going to be there in our medicine. But I think if you participate very actively multiple times, it happens so that your even performance in the exam, not I will say the exam or practice, everything is going to be smooth. So thank you very much, and I should appreciate both the expert, Dr. Manjeer and Madam Chandana. Sure that all of us learned a lot. Your presence have made the difference in our learning, and all other students. I should not forget the mentor Nisha. I remember her that when she was resident, but now I see that how she's grown up. She's now associate professor and the mentor, and I will say you have done a very good job with this SAN for this preparation of the case.
Sir, thank you so much. Rather, I want to thanks to you, sir. And sir, we were really lucky that we had done residency under your guidance in your institution, that we were able to do case presentation under your guidance. But sir, I want to say one thing, because of this online platform and because of this technology, this generation is really lucky that they are able to present a case in front of you, and rather so many residents in at a time, 100 and thousands residents can get your benefit at a time under your guidance. Sir.
Yeah, even we are able to connect with the experts from distant places, from
yes,
any
sir.
place, I will say definitely.
So sir, this is really a good media. And sir, one another thing, sir, even after becoming a teacher, being a teacher for 15 to 18 years, still you are a teacher for us, sir. And there are so many things to learn from you, sir, how to be academically active and more active day by day, sir. You are, sir, really a inspiration for us till date, sir. Thank you so much, sir.
Thank you so very much. So I think we'll have to end over here, and over to Dr. Nehal, to you. Thank you very much.
Thank you very much. Thank you.
So much. Thank you so much, both the experts, Manjeer Ali sir and Dr. Chandana. We really enjoyed today's expert comments and the discussion. I thank all the participants today. It was really a very nice discussion. I was there even off the video, but throughout the case discussion, I enjoyed a lot. And,
I think one point which I would like to convey all the students, as Dr. Nisha mentioned, at present there are multiple places these type of classes are going on. I think with this active participate discussion, attend, simultaneously read, I'm sure before the exam you will be ready. You know, the Tuesday we are conducting, Thursday Amrikar sir is conducting, even this credit goes to Dr. Nehal and Yogesh Bhai, that this platform in the Gujarat state, they have established so nicely that all of us are learning. So I will say all the students, whenever it is going on, please join, and this should be the very good learning for all of us. Thank you very much, Dr. Nehal.
Thank you so much, Nisha Bhai, for mentoring the presenter. Thank you, Sayan, for the beautiful presentation. And
thank you, Nehal, madam.
The students who have joined, that if you have any case, you can directly contact to me. You have my number with you, people. So you can contact me whenever there is any case ready from your side, and we will be happy to receive it. So thank you once again, all of you. Thank you
very much, and good night.
Good night.
Thank you so much.
Thank you.
Thank you for providing this platform. We have the certificates, but I think because of the time constraint, I will share it personally.
Thank you.
Thank you very much.
Thank you so much to all of you.
Thank you, sir.
Thank you so much, all.
Good night.
Thank you, sir.
Good night.
Thank you.
Good night.